So today I'm going to talk a little bit about some innovations and what I'd like to say getting to yes. How many times have you gone to a consultation and you've been told, well, we can't do that. You've already had radiation. I'm sorry. Well, I like to get to yes and figure out ways that we can actually be able to improve control, decrease side effects, and improve cure. So today I'm going to talk a little bit about reirradiation, yes, absolutely. Treating prostate cancers again for recurrent prostate cancer with the use of barogel spacers, hyaluronic acid spacers, getting to yes. So this picture really is just looking at that space in between the top of the rectum, the anterior rectal wall, and the back of the capsule of the prostate. And these spacers help us to deliver reirradiation and absolutely protecting the prostate, which allows us to, again, do reirradiation in focal areas of the prostate and extend control and cure. So what are the options for managing and curing clinically localized prostate cancer that's been previously radiated? And yes, for cure. Well, the one option would be long-term ADT or androgen deprivation. And for men that have been on for hormonal therapy and for long periods of time, you all know what the side effects are with fatigue, hot flashes, weight gain, hair loss, bone thinning. That's no treat. Obviously, it's very effective, but if we can prolong that or not require that, even better. Second is surgery. Taking the prostate and the bladder has to come out at the same time after radiation. Well, that also can be very morbid, and very often those patients will require a long-term suprapubic tube or a tube that goes into the bladder through the skin above the pubis to drain their bladders because they have so much scarring. Reirradiation that we're going to talk about, and that is with the availability of new technologies such as an MRI linear accelerator, proton cyberknife, or accelerator-based reirradiation, placing a spacer to protect the rectum. So, before we talk about reirradiation, so what is a spacer and where does it go and how is it done? So here on the on my left is a screenshot, an MRI scan, which you can see a white balloon type structure. It is not a balloon, it's a gel, and it's called barogel. So what is this? And here next to it is top to bottom an axial cut, and you can see it's above the rectum, and here it's below the bladder, very high. So what is this substance, this hyaluronic acid? Well, number one, it's natural to the body. And secondly, this is the same medication under a different name that the plastic surgeons have placed in the face for reconstruction, for cheeks, for lips, over 50 million times. And it's very, very, very safe. Once placed, it stays in for about a year or so and then starts to dissolve. You'll never know it's there. So here you can see I was able to place it under this prostate from the apex at the bottom of the prostate all the way up well above the seminal vesicles, totally displacing the rectum. And here from top to bottom, because this is really the cuts that show you how you've done, how symmetrical, you see this white disc-like area. So that's the hyaluronic acid. It's a gel, it's soft. It moves with the rectum, so you will not feel it with bowel movements. You really will not know it's there. And we're able to shape it depending on where we need it. So here, these rabbit-like structures just above are called the seminal vesicles. So we can get this barrier or gel very high. And as we work our way down, you can see now we're just at the base of the prostate. We still have very, very good displacement. Here we're getting down towards the lower part of the prostate, or what we call the apex, and still very, very good displacement, as you can see on the arrow. And here, all the way down below the prostate, we still have displacement, which absolutely gives us protection of the anterior rectal wall all the way down below the apex. So how do we use this in reirradiation? Well, I'm going to talk to you a little bit about some cases, show you pictures, because a picture is worth not 1,000 words, but 1,000,000 words, just to show you how where patients previously may have been told we can't do this, we can't treat, or the side effects are going to be high, and show you how we do take care of this. So this is a 66-year young gentleman with T2C prostate carcinoma involving both sides of the gland. He had Gleason 3+4 or 7, and he had surgery in 2010. He actually had radiation in 2016, and he had a PET scan. Now, we all know about PSMA-targeted PET scans, which showed 3 areas. One was in the left seminal vesicle remnant, and you can see on screen left, there's a little yellow dot. That's the top of a remnant of the prostate, even though the prostate was out. The next screen is the target. So there's my target. Now, underneath this, you can see a kind of a grayish kind of disc-like structure, and that's the spacer. So it displaced the remnants far away from the rectum. So this patient is going to get reirradiation of a PSMA target in a previously radiated field. And at the same time, we'll treat those 2 lymph node areas again for cure. So here you can see the spacer. The white almost looks like toothpaste, pretty wide and also pretty high, well over 1 centimeter. And here's the recurrence at the medial seminal vesicle remnant in a previously radiated field. And here from the sagittal or side to side, you can see the target and that white structure that looks like toothpaste, which is the barogel, which is protecting the rectum maximally. So we can deliver a highly focused dose in a previously radiated field for cure. So what about if the patient had seeds, low dose rate seeds? We used to do these years ago. It's still being done now, and it's definitely a very reasonable way to treat prostate cancer. So this is a 66-year young gentleman, notice I'm saying young, with grade group 2 prostate cancer, Gleason 3+4, presenting with an initial PSA of 16.7. So the patient had IMRT, which would be 5 weeks of treatment followed by a brachytherapy boost with seeds. He did not receive hormonal therapy. He failed in the pelvis, in the lymph nodes in 2019, and received pelvic radiation and hormonal androgen deprivation. That was 50 grade in 2021, and hormonal therapy along with abiraterone. He presented to us with a new elevation in PSA, and the PSMA target showed this medial seminal vesicle remnant just above the prostate, which was radiated with seeds. So it's just above the seed line. And you can see on the sagittal, the 3rd slide, the arrow pointing down to where it is just above the seeds, right exactly on that level. So how did we treat this? Well, the first question is going to be is, can you get the spacer in a previously radiated area? And number 2, under an area that had seeds, is there going to be a lot of scarring? Well, so on the first slide on the left, you can see the very small, tiny area of recurrence that was hot on the PET scan in the seminal vesicles. And that's how we got the spacer in. You see that spacer just underneath it. We were able to deliver a very focal dose to that area. Well, this does happen, not uncommonly. So this is another gentleman, 80 years young, who had a low dose rate iodine 125 seed implant many years ago, 2010, for early disease, fairly low grade, grade group 2. And he presented with a rising PSA now 9.2 with a positive PET scan. Again, right at the edge of the seed line on the first of the 4 slides. You can see it on the second, and you can see it on the sagittal, the third side to side sagittal, just at the tip of the prostate where the seminal vesicles would be. And on the 4th slide, which is the MRI, you see the target, which is the dark black area that the arrow is pointing to. And that's the current area that the PSMA PET scan is showing us. And you see the balloon underneath. Well, it's not a balloon. It's the hyaluronic acid. It's the gel that I was able to shape like a balloon-like structure. It's very soft, and you can just define that gel just to that area. You know, unlike other spacers where you really can't define where you want to put them, like this new balloon or previous spacers that we used to use, this is soft and very tolerable, and we can design it and put it wherever we want to, and that's where I was able to put it. So going top to bottom, you can see the seminal vesicles on the first slide on the left, and I was able to just to define it just under that left seminal vesicle, and then coming down from top to bottom a little bit more just under the seminal vesicle target. And now we're down to the lower portion of the apex of the prostate, and we still have a good amount of gel, and you can see the black dots, and those are the seeds. So we got very good placement from top where the target is all the way down to protect the lower portion of the rectum, even though we're really just treating a very small target. Very well tolerated. Patients do not have pain. They do not feel fullness. They do not feel discomfort moving their bowels or uncomfortable at all. And you can see on the last slide, side to side sagittal image, the placement of the barogel spacer under the prostate and just above the rectum. Okay, so what about if your prostate extends outside, your prostate cancer outside of the prostate? We call that extra prostatic or extracapsular extension. Very often we were told, well, we can't put in rectal spacers because it's outside the prostate. And so the rectum is at higher risk and it's going to get a higher dose, which can result in chronic irritability and bleeding. So this is a gentleman who had a prostate cancer, fairly bulky, and you can see it's extending into the left extracapsular position. Pretty bright on the PSMA PET scan. This is the MRI scan. And on the slide on the right side, you can see that extension extending outside the capsule and how close it is to the anterior surface or the top of the rectal surface. So the question will be is, can we get that in? So of course, we like to say getting to yes. You know, can we put a spacer just underneath that area so we can get a high dose exactly where we need it and absolutely protect the rectum? So here you can see, I was able to get the first slide side to side or a sagittal image. I was able to get that spacer in really very nicely demarcated from above the seminal vesicles, top of the bladder, all the way down to the apex of the prostate. The middle slide is, again, a transverse image or top to bottom, and you can see it's very, very well demarcated and circumferential, protecting the entire surface of the rectum. And again, really, it's very hard to do this with any other spacers. Here it's totally symmetrical with excellent displacement of the anterior rectum and the prostate. And so the prostate is probably a centimeter away from the anterior rectal surface, which is a mile for us in radiation to deliver therapeutic doses. So again, top to bottom, this is interesting because I'll be able to show you an procedure image, because patients are actually awake with a little mild sedation. So the slide on the left is under the SVs, the seminal vesicles, which look like rabbit ears. We had to protect all the way up. This is a patient with capsular penetration posteriorly or behind at the back of the prostate shell. And as we go down, you can see the spacer is very well demarcated mid-gland and now all the way down below the prostate, which actually helps to decrease the dose to the penile bulb as well. And the last slide, the one on the right, is actually the gel with an intra-op picture. So this is what it looks like. And it's almost very spongy. It's a very soft gel. And here we have at least 1.5 centimeters of lift. So the entire back of the prostate is totally protected. And the patient will never feel that. Okay, so I showed you a lot of MRI pictures, and we're going to look now at a patient that had a previous procedure on their prostate to improve urination, and that's called a urolift. Series of clips that help to open up the urethra to help with urination. So this is an 80-year-old gentleman. This gentleman was very functional and wanted his prostate cancer treated, did not want to receive hormonal therapy, which is very reasonable. So our plan was to proceed with stereotactic body radiation, or SABR, stereotactic ablative body radiation. And you can see these clips on the top, which were the urolift. So we were able to get the spacer, which you can see on CT on the final slide, which is this darker area under the prostate and above the rectum. So there was no limitation from the previous procedure. So are there difficult cases, and are there patients that we should not be doing? Well, there always are, but this was a 65-year-old gentleman who lived in a personal care facility, who was a bilateral amputee, very thin, less than 100 pounds, had a very curable prostate cancer, and really no other medical conditions other than his vascular disease and diabetes, which required the amputations. He was cared for very well, and we discussed placing the spacer so he wasn't faced with the possibility of rectal irritation from radiation, or what we call proctitis. And again, this patient was going to be treated in the quickest way, in the stereotactic way, in just 5 fractions. So here, on the other slices, you can see this area where the arrow is pointing to on the slide on the left was a little wider. So here it's very, very thin. So the question is, are we going to be able to get the spacer in? Well, in fact, as we tried slowly, you can see we got a very, very nice separation, well over 1 centimeter, probably 1.5 centimeters or more, to separate the prostate capsule from the anterior rectal surface. This is an intra-op picture showing from all the way from the apex all the way up to the top of the seminal vesicles, very good separation. And this patient went on to stereotactic treatment, has done very well. So what kind of other technologies do we do, and how do spacers help us with this? So this is an 83-year-old gentleman that had almost 80 gray or 8,000 centigrade for definitive treatment in 2015. And he presented with a biochemical recurrence and a PET scan, which was positive for recurrence within the prostate gland. His PSA had gone down as low as 1.7 and now was 4.24. Obviously consistent with disease. So here's his PSMA PET, which is our PSMA PETs are our friend. They help us to help target areas of recurrence where before we wouldn't see them on CT. Sometimes we'd see them on MRI, but having the PET scan helps us to further define the target, which we then can see better on MRI. So this patient had 3 fiducials, or little markers in the prostate from previous treatment. And you can see he has two posterior lesions, one on the right side. Remember, we're looking at mirror images, and one on the left side going posteriorly to mid and central gland. Fairly large volume. Coming down, it went all the way down to pretty much at the apex of the prostate. And the last slide on the right is looking at the tracer of one of the lesions from right to left, or a sagittal image. So there's the sagittal image, and the third slide, the slide which is the furthest to the right, you can see one of the lesions, the gray area in what we call the peripheral zone of the prostate. And you can see where the rectum is and where the prostate is. So this is an intra-op picture where you can see the gel. This is an ultrasound. So these are done with transrectal ultrasound for real-time imaging during placement. The whole procedure takes 20 to 25 minutes. So we got excellent separation despite the previous radiation of almost 8,000 centigrade. And this is the gel. And here on MRI imaging, going from top to bottom, you can see excellent coverage covering the right and left side of the rectum, very circumferential, well over a centimeter, going all the way down to the apex of the prostate. All the way down below the prostate tissue. Okay, so what else would be a difficult situation that we are faced with? And we do see this. 70-year-old gentleman who had previous cryosurgery, freezing the prostate to the entire gland in 2020. And he had a recent elevation of his PSA to 4.1. So we decided to treat this patient with MR-guided stereotactic radiation. But first, we needed to get a spacer in to be able to splace the rectum, because often cryo can be associated with ulcers of the rectum, depending on how much freezing there is. Not always, but at times. So you can see the PSMA PET scan on the slide furthest to the left. There's bladder, which is bright, and then the target. And here on the second slide, you can see the gray area, circumferential area, and that's the actual target of viable tumor. The third slide, again, sagittal image side to side, is the spacer in green, followed by the purple area, which was the residual prostate tissue that we were going to be treating. And the fourth slide is top to bottom, an axial image or transverse image. And you can see the arrows pointing to the spacer below the prostate to help protect that anterior rectal wall. So yes, we can do this after cryo. So this is such a lovely Filipino gentleman, 83 years old, one of our first patients that we treated for recurrence on the MRI linear accelerator, and that we put a barogel spacer in after previous treatment. So he had treatment in 2005, and following his PSAs, his PSA went up to 5.5. He had grade group 3 disease, or Gleason 4+3 disease, on the biopsies. So we put in a spacer, and here you see very, very nice displacement of the prostate. And the red circle is where his recurrence is. So this is a recurrence, and here it's demarcated on that orange-yellow type area on the PSMA PET. And that's our target for reirradiation. So here, the arrow is pointing down to where we put the barogel spacer, and on top of that is the prostate. Very often, patients will recur very low, just above the penile bulb. So the penile bulb basically has all the vessels, and they are very important for ejaculatory function. So you can see here the bright yellow circle at the bottom of the apex of the prostate. And this was a patient that had almost 8,000 centigrade, again, 79.2 gray. His PSA had gone down to 0.1, and now it was 1.55 with the PET scan showing this area in the apex of the prostate. So again, we were able to put post-prostatectomy as well, a patient with a remnant. We put a spacer in underneath this disease, and here's his recurrence. The red circle is the recurrent disease. So yes, we have an experience doing this after the prostate is removed, as long as we can see a target on MRI and PET scan. So reirradiation for cure. So, very often, again, we see recurrence is very low after surgery because when they take the prostate out, they have to reconnect the urethra. We call that the anastomosis. And that about over 60% of the time is the areas where there can be some residual cells. So this patient had a prostatectomy for Gleason 4+3 disease. PSA was less than 10. He had multiple biochemical recurrences treated with hormonal therapy. And he had previous radiation in 2004 to 64.8 gray. So he had a rising PSA, as you can see here, up to 12.0. And here you see the end of the bladder neck, but there's a slight blush on the PSMA PET under the bladder, and that's our target. So here you can see the red circle is our target, and we were able to put a barrigel spacer. Again, I can place this just under the lesion. I don't have to put it on both sides to help protect that anterior rectal wall. The middle slide is actually a depiction of what it looks like putting the gel in, very soft, and how we do it with a needle. This is all done through the skin under ultrasound guidance. And here is this patient with a very nice barrigel spacer. This is the target, and they were treated focally with stereotactic radiation right to that area. So patients very often will ask, well, I was told my prostate is too large, and there may be rectal extension. So are we able to protect the rectum, or do we have to treat some of the rectum? This is a very nice gentleman who had a very large prostate, but normal urinary function. So we decided that we would attempt to put a spacer in to protect his rectum because he had to get very high dose for cure. We did treat him stereotactically as well. So here you can see the prostate almost looks like a cantaloupe pushing up into the bladder, but underneath the gray area is the barrigel spacer. So we're able to get all the way from the base, the top of the prostate, all the way down to the apex and under the apex to help protect the prostate. Well, that was a lot of cases, but I just wanted you to get a sense of what we're doing, how we're trying to improve control and lessen side effects and give other options, particularly for people with recurrent prostate cancer. In our experience, after previous radiation, external beam, seeds, or after surgery, and even after surgery and radiation, to focal targets that PSMA, PET, and MRI help us to define. And that's the end of my talk. I hope it wasn't too long and boring, but nice pictures anyway. Certainly, if patients have questions, please email me. I put my email at the beginning of the presentation. Happy to talk to you at any time, or call me, and we can talk about options or cases. There's excellent physicians in the country that are doing this. And thank you very much. It's been my pleasure to do this presentation today for ZERO with a fantastic group. Thank you so much.